this graded today, but I'll have it done by noon tomorrow for sure, okay? We might be able to, we'll see, but I'll try it definitely by noon tomorrow. We have these two chapters to cover today. The test over diabetes is next week. So hopefully this is primarily, like I was telling AJ, there's only about 15% of this that is gonna be new to you guys. The rest of it's really review. So if you're comfortable with diabetes, high five. If you're not, you better get comfortable. Okay? I think that's an easy way to say that. Chapter 51 talks about diabetes in general. So one thing to think about is the cause of diabetes. Genetic, immunologic, and environmental. So genetic, immunologic, and environmental. Hispanics have the higher population of those that are predisposed for genetics-wise for their diabetes. Also with that said, there's modifiable and non-modifiable factors. So modifiable would be weight and lifestyle. So it'd be a diet change, an environmental change, that whole kind of a concept. And then for non-modifiable, age. Age is also a precipitating or factor for a risk or cause. Functions of insulin, all listed on that this slide for you guys. I'm not going to read them. Just please make sure that you review them as you go along. Classification of diabetes. Type 1 diabetes, type 2 diabetes. Remember, way back when we used to hear insulin-dependent diabetics and non-insulin-dependent diabetics. You notice throughout the world now, we don't call them that. Type 1 diabetics used to be the ones that had the insulin. But now we know with long-acting insulins, the type 2 diabetics are also getting insulin. So we don't classify them as who's getting the insulin and who's not. It's all based on blood sugars, and they have found that the long-acting insulins help the type 2 diabetics throughout. Gestational diabetes, it is classified when the pregnancy, when they're pregnant of course, secondary glucose is greater than 200 mgs per deciliter, so milligrams per deciliter. So when it's above 200. Other genetic factors that are associated with diabetes, those patients who have Down syndrome, disease of the pancreas itself. So whenever you think of the pancreatitis that we mentioned, we already should know that we're going to be doing sliding scales with those patients, right? Because their pancreas is inflamed or infected, and it can't produce the beta cells to get the insulin and all that. Cushing's is also another one that is associated with diabetes. Hyperthyroidism, and then infection. We know infection causes blood sugars to elevate. Why? Because cooties love to thrive on sugar. That's how they grow. And so we have to make sure that that blood sugar, then we lead into those complications that are associated with elevated blood sugars. So type 1 diabetes is destroyed, it's deterioration or destroying of the beta cells itself. It is considered autoimmune. And then before the age of 30, they classify that really truly, anybody under the age of 30 as juvenile, or anybody younger than that with the type 1 diabetes. Type 2, we said Hispanics originally in general. Now getting in more to the type 2 diabetes, it's also the Hispanics and the African Americans that have a predisposed, because of genetics, predisposed with elevated blood sugars. It's considered that insulin resistance, usually it's classified up over that age of 30. Doesn't matter what genetic base or race or culture. It could, if you're obese, you have a higher chance of diabetes as a whole. And then of course environmental plays a role with that. So risk factors listed there, make sure you look at those. And then our signs and symptoms or clinical manifestations. We know hyperglycemia as the 3 polys. Polyuria, polydipsia, polyphagia. Polyuria means what?
Urinating.
Too much urine, right? Polyphagia? Too much hunger. And then what about polydipsia? Too much thirst. So that is a sure sign that somebody has hyperglycemia. When you get into the second bullet of clinical manifestations, you'll see a little bit of deeper dive. This deeper dive comes with the fatigue, the vision changes, numbness in the feet and hands. We know that as neuropathy. What vitamin can we help with that? the winner. We also know patients are on Neurontin. We know Neurontin as a what? It is gabapentin, but what class is it in? Big scenario. It's anticonvulsant. But do we use it for anticonvulsant? No. We use it for those patients with the nerve pain. Hence, these patients with diabetic neuropathy. And then, when we go on to sudden weight loss, those patients, oh, I forgot that, gosh darn it. I remember the iodoform guys, but I forgot the juicy fruit, gosh darn it. So, patients then have the weight loss with abdominal pain, and that gets us into our GKA, our diabetic ketone acidosis. And we'll talk about the juicy fruit here in a second. We'll talk more about DKA. Fasting blood sugars, NPO at least 6 hours. That is a goal. You can't do a fasting blood sugar if the patient hasn't fasted. That's the worst thing that you can do, is take a fasting blood sugar after they eat. They have to fast. Randoms, given numbers there. The American Diabetic Association says a normal blood sugar level should be 70 to 99. Now if you talk to any diabetic, that 70 to 99 world is hypoglycemic for them. But the American Diabetes Association really had made that up because those patients that are newly diagnosed, we don't want those comorbidities or those complications to happen. So again, if you mention, oh, you have to have a blood sugar at 80 in order to be good, the diabetic's going to laugh at you and say that'll make them hypoglycemic. So American Diabetes Association does say 70 to 99 though. Glycosylated hemoglobin, this measures the glucose attached to the hemoglobin for 3 months. 3 months, okay? That is a surefire way to find out that diabetic is truly a diabetic, right? So if they have a glycosylated hemoglobin, the markers are anything less than 6%. 6% is really the marker for diabetes. We like to see non-diabetics, of course, lower in the 5s. But as they're creeping up to that 6, then we begin to watch them a little bit closer. Anything with complications to avoid who are truly diabetics, we want them below 7%. Now the question comes into play, how long have they been untreated with these diabetes, right? The more the number goes up, the more complications they have, the microvascular and the macrovascular, which we'll talk about here in a second. So numbers wise, we want them less than 6 and then less than 7, but of course it is truly a marker after that for the diabetes itself. Dietary management. Calorie controlled diet, so American Dietitian Association. One thing we're going to look at is 1800 calorie diet. And the reason I picked 1800, just so you could see the percentage of what they're eating based on their pretty much restricted or calorie controlled diet. They have 50 to 60% of the calories is from carbohydrates. 30% of the calories is from fat. And then 10 to 20 of the calories is from protein. So you may already be thinking, which I hope you are, that if I give more protein to my diabetics, one of the complications is renal failure, right? So we have to control that protein. And that's on a restriction. Just like we know carbohydrates turn into what? Sugar, okay? And then fats, we need the good fats. We don't need the bad fats. Because that may lead into atherosclerosis, coronary heart disease. We don't need any of that on top of everything else. But remember, when I mention diabetes, you're automatically thinking, what's wrong with their vessels? Small vessels disease, right? We know it's from strokes and smoking. But if you think about it, when I remember that picture, do you guys remember the picture where I had him farm? With the vessel? And then we had, and I think I put it up, didn't I, for cholesterol here too? Yes? Okay. So we have the cholesterol, and then we have the sticky platelets, and then we have the black dots, or brown dots technically. That was our sugar. That decreases that lumen because it's sticky. It's a sticky world, right? So that flow is not going to happen as easy, especially if they have the sticky platelets, right? Because we want our platelets to stick for the most part, not in a small vessel world. The role of the nurse with a diabetic patient is truly 2 things. 1, diet and medication administration. So diet, if you run into questions that you don't have answers for as nurses, there's somebody called an RD, a registered dietitian. consult them, come up and have a discussion with the patient. If your facility has diabetic, educator, please consult them to come up. Don't get stuck in that world of answering questions you may not have answers for, because you want to protect that patient and those complications. That's one soapbox. The other soapbox is medication administration is just not only for you to administrate, but for you to teach the patient how to administrate. Okay? And some of the things you already know is the right to assessment. So you want to make sure that you check their blood sugar before you give their insulin, right? Because when we get into the onsets, the peaks, and the duration of actions of insulin, we need to know when our patient is going to have a drop in that blood sugar. Or what do we need to see, or how do we see, or what do we see with that patient and the insulin they're getting, okay? So we always remember the right to assessment, checking that blood sugar level for sure before we administer any anti-diabetic lowering agent. Meal planning, self-explanatory there. The glycemic index there. And then other dietary concerns that are associated with alcohol. Alcohol causes hyperglycemia. It will increase blood sugars. Sweeteners. One thing about sweeteners is aspartame. Remember, some people are sensitive to aspartame. So they might think that they're having lupus because they have joint pain. And so they go through all the testing, and it's just they are holding in to aspartame. You guys may already know that when you drink a lot of aspartame as well. Reading the labels is important to discuss with your patients.
Maybe.
Yes.
Are we going to go over glucagon?
We'll mention it.
Can I point something out?
Sure.
So alcohol, if it's carby, it will increase the sugar. But what will happen is your liver is going to not release glucagon if needed. So what will happen is they will go low, especially if it's in the liver. And when a diabetic goes, especially type 1 goes low, we would give them glucagon to release their own liver stores, and it won't happen. You can't save them if they,
Can't use their own.
yeah.
Thank you.
I can use anyone.
Yeah. So when exercise does all of those things, right? But patients that are diabetics, they have to plan accordingly with their intake. They have to plan accordingly with their insulin as a whole. Exercise precautions, make sure you read that. Make sure you read your exercise recommendations. So getting into the nitty-gritty of insulin therapy. So one, the blood glucose monitoring, of course, before breakfast and before, dinner. And then we know about the sliding scales, which we'll mention here a little bit more in a bit. So one thing is rapid acting. What suffix does that have? Log. How fast, literally rapid, is the onset? 5 to 15 minutes. If you just put 15, you're going to get it wrong. It's 5 to 15 minutes. Okay? How about the peak? 30 minutes to an hour. If you look at different literature, it's going to tell you something different. Duration of action is up to how long? How many hours?
2 to 3 or 3 to 4 minutes.
It's 4, up to 1. Yep. So 4 is good. Nothing over 4. Because there is some controversy when you look at different literature, it says 3 to 4 and it'll tell you 2 to 4. But the whole idea too is it uses for patients who have a high and we have to bring it down. Short acting, we know as what? What insulin is short acting insulin? What's the name of it? Starts with an R. Regular short acting insulin. When's the onset?
30 minutes.
30 minutes to an hour. And it also can go 3 to 4 or 2 to 4. So that's where the controversy lies. So it's still up to 4 hours, period. So these two that I mentioned are what you're going to see in your sliding scales because they are short acting. We'll talk more again, like I said, about the sliding scales. Is regular, how about this? Is short acting or regular, rapid acting good for IV? Which one can be given IV? Rapid or regular? Regular. Regular insulin, your short acting, is the one that is given IV. So if you have a patient on an insulin drug, when when they tell you it's insulin, before they even tell you that it's a regular insulin drip, it's regular insulin. It's usually in a 1-to-1 ratio. So we have 1 unit to 1 ml. That is standard. So if I'm in an ICU with a patient who's on an insulin drip, I will be checking that blood sugar at least every hour, right? Because we said the onset of regular insulin is 30 minutes to an hour. So needless to tell you, that patient is a one-on-one with an ICU nurse. A lot of your IMCUs or your med surgers usually don't keep them on a general floor like that. They could, staffing, blah, blah, blah. However, every hour, we need to monitor that blood sugar.
What was the peak?
It doesn't matter.
Oh,
Yeah, it doesn't matter. And yes.
What, like, reasons would you need to have somebody on an insulin drip?
DKA, which we haven't got to yet. Yeah, we'll get there. I promise we'll get there. Unless I fall out or something, and then we won't. NPH, intermittent acting. That's your cloudy insulin, right? The one thing we think about with NPH or our intermittence is our peak is 4 to 12 hours. That is when we worry more about the peaks than we do anything else. Now, the duration of action is also controversial. It says that it can go 12 to 24 hours in duration. But then if that was the case, why do we need long-acting insulin, was my question, right? Did you laugh at me?
No, I said,
Oh, I thought you giggled, I'm so excited. So, with that said though, I mean truly, why would we? Now, if in the world of insulin versus non-insulin, if those patients were getting NPH, then why didn't it cover their blood sugar the entire night, is my question. So that's a question that has yet to be answered. But 4 to 12 hours is important with the peak of NPH. Now, we know medications that are in combination, right? We know that it's 70-30 or 75-25, right? So that has your intermittent with your short being your 70-30, or you have your 75-25, which is your intermittent, and your rapid in combination. Because what they need is the onset, the peak, and that duration, okay? So they need a combination, so which makes that 70-30, 75-25 longer in duration then, right? Because we know the rapids and the short are only up to 4 hours on that onset. Or, I'm sorry, duration of action is only up to 4 hours. So, very long, I made an exaggeration, but long acting, we don't have to put very long. Long and very long meaning the same thing. One thing about that, it's for overnight control. That is why patients that have type 2 diabetes will use that as an overnight. Don't get me wrong, some will use it during the day. But the original goal of this function of this insulin was overnight control for those type 2 diabetics. Because they were waking up and their blood sugar was elevated. And so they couldn't figure out why. And so here comes the long-acting insulin. Levemir, Lantus. Now if you pulled out Lantus, the insert, it will tell you that Lantus is 24 to 36 hours of a duration of action. I'm happy if you know it's over 24, because Levemir is only 24. So with the two different types being under the same kind of category, 24 hours is good. Yes?
what about Basaglar?
Good question.
Oh, the same?
Yeah.
Tresiba is amazing, it's 48 and it's
Oh,
true to
wow.
it.
Yep,
Yeah.
good.
Okay.
Good. So there's more stuff out there. One thing also, beta blockers. Patients who are receiving beta blockers will have a lowered blood sugar. And that is because it interacts with these insulins and it works with any diabetic medication, whether it's insulins or orals. It will cause their blood sugars to decrease. So we have to keep that in mind with our beta blockers. So, symptoms, make sure we know and be able to recognize hypoglycemia and hyper as a whole. However, being able to recognize when patients have hypoglycemia from insulin, we need to know what our patients will look like. So what will a hypoglycemic patient look like? Okay. Could be agitated, confused, yeah. It could be non-responsive. Yep. Stupor, right? Could have the shakes, right? Restless, tremors, tachycardia. Okay? So, with that said, making sure that we're monitoring that blood glucose, either like that twice a day, before breakfast and at bedtime. I lied. At breakfast and at dinner time, or we can do AC and HS, that's where I saw the bedtime, before meals and at bedtime, so they need it more frequently. But keep in mind, one thing is self-administration, easy access for the patient is the belly. When you're going to administer insulin to these patients, you ask where they want their sub-Q injection. Okay? They might like it in the belly, not in the arm because it hurts too much. Or the inner thigh, any place there's adipose tissue. So that's one thing to keep in mind. Insulin pumps are great. They went away, came back, they're slowly around. One thing about insulin pumps is juveniles can be a kid. They can adjust based on what they're eating, so they don't have that dip and raise of their blood sugars, right? And so it controls the complications as long as it's operated correctly. And of course, maturity and all that plays a role as well. Complications of diabetes. We have the hypoglycemia. I flipped too soon, sorry. Yes. So oral anti-diabetic agents that we need to mention. So, two of the classes that I want you guys to remember and know is your biguanides. This is your metformin. And that is your generic name. Okay? What the biguanides, specifically the metformin that we're talking about, inhibits the production of glucose. A lot of people are using metformin now as an appetite suppressant and weight loss. Because it inhibits the production of glucose. The other ones that I want you to know and the trade name, I'll get you the generic. I haven't written it
It's pioglitazone.
down. Yes, PARG.
PIO.
PIO.
Glit. GLI. TAZONE.
Thanks. That's your generic. This is insulin actions are at the receptor site without insulin secretion from the beta cell. So insulin actions at the receptor site without insulin secretion from the beta cells. So complications of diabetes as a whole: hypoglycemia, DKA, which we're going to talk about in more depth. Yes.
Would you mind repeating the action of the drug?
Sure.
I'm sorry.
You're okay. Insulin actions at the receptor site, or attaches at the receptor site without insulin secretion from the beta cells. Without insulin secretion from the beta cells.
Thank you.
Welcome. Everybody's good? Good?
Yeah.
Okay. So hypoglycemia, DKA, and then the HHNS or the HHS. So hypoglycemia, we already mentioned the symptoms. Again, considering the ADA, it's less than 70. Your book says below 50 or 60. Again, when your patient is showing signs, check their blood sugar. That we mentioned, the agitation, the confusion, the diaphoresis or the sweating, the tachycardia, tremors, restlessness. Assessment is onset wise, and then management. So one thing is treatment should be immediate. just some helpful hints that your book gives you. Some glucose tablets. Don't be that nurse, because I will hump you, that gets a glass of orange juice and pours a bunch of sugar in it. And then gives it to your patient. The reason why is what's gonna happen to that blood sugar with a bunch of sugar? It's gonna spike and crash again. So we know, what do we need to give these patients in order to sustain that blood sugar? Protein. They need protein. So yes, we can give them initially that orange juice, right? Not pouring sugar in it. But we have to get them something to eat, to sustain so they don't drop. Because that's where those complications come in. We're doing the job. This is just some other helpful hints. Another thing is the frosting that you write on cakes. A lot of people will do that sublingual, and then they'll eat something, okay? Just to bring it up enough, the symptoms go away. But again, they need that sustaining of that protein. Emergency measures. Glucagon, which we mentioned earlier, and I didn't, but AJ did. And then D50, if it's available. If you have an IV, give D50. It is, one, really thick to push, but if you don't have it, glucagon may be the other option. Flipping the coin now to DKA. These are your patients who are in metabolic acidosis. pH is what?
Less than 7.25.
So low, and then your bicarb is what? It's acidotic, so it's less than. So your pH is low and your bicarb is low. That makes them metabolic acidosis. So when a patient comes in, by discussion purposes here, we're going to say that DKA has a blood sugar greater than 600. You can pull it up, and all different these computers are going to tell you something else. For discussion purposes, over 800 when they have these other symptoms that we're going to mention. So over 600, they're going to be dry. You're going to do an ABG because they have rapid, shallow breaths. They're puffing them at you. We know that as cool, small respirations. And when you open that door to walk into that patient's whatever, you're going to smell an acetone breath. That's where the juicy fruit. So that is when you, if like your neighbor was chewing juicy fruit right now, you'd be able to smell it. Even walking into the room, you could smell that sugar breath, okay? Also, of course, they have the polyuria, polydipsia, all of that goes along with that. Ketones in the urine as well. We would do a urine dipstick because they have polyuria. You might as well grab a urine, right? You're going to see ketones in that urinary dipstick. Also, that glucose is going to be elevated on that urinary dipstick as well, okay? So that is how we know. Now, things that happen is they are dry. Dry, dry, dry. So we need to hydrate 0.9 normal saline. And then we find out how high their blood sugar is. What do we need to give them for that reason? How is their electrolytes? Because it could be an imbalance. And then go from there. The goal with these patients is prevention. There are some sick day rules that we need to consider. In a sick day rule kit, there should be glucose, blood glucose strips, and urine dipsticks. So if they have a suspicion, because they're sick, we said, infection causes blood sugars to elevate, okay? So by having an infection, they very well could have a high blood sugar. They check their urine, they check their blood sugar, and that's what they come up with. The reasons why, some of the rules that are associated with this prevention idea is if they have nausea and vomiting, they should not stop their insulin. Because again, infection causes blood sugars to go up. So that's the second thing, blood sugars elevate with illness. The reason why they should seek medical attention with their sick day is unable to keep any food down for at least 6 hours. So no food down for 6 hours. They have a decrease in 5 pounds of weight in 2 to 3 days. Their temperature is above 101.5. Truly 101, that's a pretty high fever, right? That's when we start medicating. Or all of these will supersede airway, breathing, circulation, right, if they're shortness of breath. Then they have to seek medical attention with these sick day rules. So rehydrate for DKA. Insulin would be regular. notice the bolded area. Please make sure you read and know that statement. And we worry about potassium. So we very well giving the insulin and giving which we push that potassium back in the cell. Or maybe they have renal failure. We need to get hemodialysis involved. So heart monitor for that potassium for sure. Then you might want to do a magnesium, right? Because they're friends. And then calcium comes into play as well. HHNS. Commonly seen in older patients, older adults, that have a history of type 2 diabetes or no history whatsoever in those older adults. By definition, it's your second bullet. It causes the blood sugar to go up and the sodium levels to go up. One of the things is it has a high mortality rate, it's hypotension, and there's glucose in the urine, they're dehydrated, and their blood sugars are elevated. So vigorous 0.9 over 2 hours, then, and you're like, well, you just said that it was high in sodium. There's a reason for that, okay? Then you would give half saline after that. Monitoring, of course, that fluid and electrolyte replacement stuff. Electrolyte, sodium, potassium, phosphorus, and chloride. Because of fluid administration, that blood sugar should decrease. We, of course, monitor the blood glucose. Now that leads us into long-term complications of diabetes as a whole. So, with our macrovascular, those are big vessel. And then our micro is our smaller vessels, for comorbidity-wise. And then, assessing these patients. So of course, skin assessment, right? We have to be very careful with these patients to educate them about don't check the bath water temperature with your foot. Don't go and get a hot bottle for your pumpkin and squirt it on your wrist. Anything that's going to cause their skin to burn, they have a delayed in healing time. And remember, glucose and cooties love each other, okay? So we have to make sure that the precise skin assessment, no hot water, no heating pads, no hot water bottles. These are not patients that we should be doing that for. There was a big recall for the last year on heating pads. Did you guys see that in the news? Big burns from these heating pads. So if you bought them within the last September to September, they're recalling them, go figure. So teaching self-care, meticulous feet care, skin care, monitoring their blood glucoses, lifestyle changes, health promotion, health screenings. All the above plays a role when it comes to our self-care of our patients. Activity change, exercise, etc., etc. Questions about diabetes as a whole?